Hi everyone, this is Sherry Bowringer. I'm an Associate Editor for Prescriber's Letter and Pharmacist Letter. This set of recommendations is about whether every patient with type 2 diabetes should take an ACE inhibitor, ARB, aspirin, and a statin. And the reason why this topic is coming up is because every patient with type 2 diabetes, there's a suggestion by paid for performance measures that every patient should be like on an ACE inhibitor or ARB or a statin, and a lot of patients should be on aspirin as well, but there's exceptions to this. So we thought it's really important to talk about the exceptions. So let's go ahead and we'll start with a question, and this one I'm going to address to you, Doug. In practice, do you feel compelled to start an ACE inhibitor or ARB in all your diabetes patients that have microalbuminuria because of these pay-for-performance?
I think it's a problem that the paid for performance, and this is not just with this issue, but with a number of issues where originally there may be some data or some thoughts, and then something gets into practice, and then we get more information, and the pay for performance lags behind what really the evidence base does. I think that many times we have patients who are hypertensive with diabetes or even mild hypertension. We aggressively treat them, and I would prefer an ACE if I can use that in that population. Right. But as far as putting everybody with small amounts of microalbuminuria on an ACE or an ARB, I don't think the data supports that.
I agree with Doug completely. That's absolutely right.
Yeah. For those who don't have the time to read the editorial, Sherry, the answer to is microalbuminuria disease, the answer is no. It's really a symptom of what could be a couple different conditions, and I would agree that by itself does not warrant therapy in the absence of
so you don't have to feel compelled to treat everybody that has microalbuminuria if their blood pressure is normal.
And hopefully some of the pay performance will change. I mean, the Kidney Foundation guidelines are coming out. We're encouraging ADA revisiting at least their grading of the recommendations. So I think the things will hopefully follow after those changes occur.
Yeah, and so Craig, so I have a question for you about this whole thing. So if we know that ACE inhibitors or ARBs prevent progression from microalbuminuria to macroalbuminuria, and we know that starting an ACE inhibitor or ARB in macroalbuminuria does slow the progression of kidney disease, can you explain why ACEs or ARBs in patients with microalbuminuria don't reduce the risk of progression?
I mean, the big issue here is that microalbuminuria is most often a symptom of just hypertension, glomerular hypertension, or underlying atherosclerosis in those small glomerular capillaries. So in a younger patient who doesn't have hypertension, it's actually not real clear that ACEs and ARBs are all that effective for preventing progression even to macroalbuminuria, let alone end-stage renal events like dialysis that we really care about. And the big confounding issue with all this literature as we go through the editorial is hypertension. So almost all those trials have hypertension plus microalbuminuria, and so the ACEs and ARBs lower blood pressure, plus probably have some blood pressure independent effects, but it's hard to separate out if you don't have a large trial with patients who really are not hypertensive, and that we still don't really have that kind of trial to say definitively that in the absence of hypertension, these are really effective therapies we should be giving to people.
Okay, and something I guess I was wondering about or kind of came home to me is with microalbuminuria, it can actually regress, right? 'Cause like on one day somebody might have microalbuminuria, but the next month they don't. Is that right?
Yeah, no, and it's the definition even by all the guideline sites is persistent microalbuminuria that they recommend treatment in, and so we define the editorial kind of how the CADA defines persistent. But yeah, there was a very nice paper, I think I cite one of the better ones in New England about a decade ago, and it just followed people with microalbuminuria, and about half progressed and about half did not progress, and some stayed the same. And I mean, it was a mixed bag. So the patients at least warrant multiple testing, and then persistent microalbuminuria would be where the debate starts. So a single finding should definitely not warrant therapy.
Okay, great, Craig. I think we were all taught that diabetes is a cardiovascular risk equivalent, and we've written several times about the fact that it's not. However, a lot of people still question us whenever we write about it. So maybe you and Steve and Doug too, whoever would like, can take that question about why it's not considered to be a cardiovascular. Okay, go ahead.
Let me weigh in and say that we have obviously done a lot of randomized controlled trials where we have diabetic patients included, and I can assure you that it is not a risk equivalent. It may have been many years ago, but it does not appear to be now, and partly it has to do with the fact that more of these patients are being treated appropriately with statins and other therapies, and their cardiovascular event rates can be very, very low, much lower than we see in secondary prevention. And so for that reason, and I also think it's pretty clear that aspirin is not particularly effective or safe in primary prevention. That is, the risks of the drug tend to exceed the benefits in lower risk patients.
Yeah, and no, it's definitely a debatable topic in primary. But yeah, no, Steve's exactly right. And there are diabetics out there, to be fair, who are probably smoking for a number of years and diabetes diagnosis that's older and hypertension. I mean, the patients that were in Dr. Hafner's kind of classic trial of a decade ago were kind of coronary risk equivalent because they were older with bad A1Cs and hypertension. But yeah, younger patients, newly diagnosed, a very different story. And everyone in practice, I think, knows that. I mean, Andy and Andrea, we all see newly diagnosed diabetics who clearly are not a coronary equivalent at age 35. So.
Right. But I'll tell you, we still get questioned on it all the time. That's why we need to talk about it. Yeah.
You know, I think a lot of the primary care practitioners don't. I mean, there are patients who clearly have high risk and patients who don't have high risk when you see them in practice. It came to a head for us in the aspirin guidelines because we were reviewing these trials where the 10-year event rate was under 10%. So there's data out there that there's very healthy diabetics even getting into these trials.
So I served on an FDA panel that was asked by the agency whether aspirin should be labeled for prevention in people with a risk between 10 and 20%.
Right.
And the committee voted no.
Right.
Only above 20%. Now, we say in here that consider it above 10%. Yeah. I mean, I think considering it is not the same as mandating it. I think it's important to think about that as well.
Yeah, it's a debatable topic in primary care, and I think it's fair to consider if a patient they really want to avoid that heart attack and stroke. I think it's fair to consider if you're in that moderate range. But I think the committee was right when Steve voted to not give it the indication per se. It's not a mandate.
Okay. Thanks so much, Drs. Williams, Nissen, and other panelists for your thoughts on those recommendations.